Welcome, everybody. Welcome. Thank you so much. We'll just wait a few minutes before we start the session.
Thank you for having us.
It's a pleasure.
Thank you very much, Dr. Hakarian.
Great to see you, Dr. Sijani. Thank you for joining. All right, everybody. I think we've got enough folks on the line. It's that time. Let's get started. Thank you so much, everybody, for joining us today for our second week of our complex lower extremity trauma course. As I mentioned last time, this is our fourth year running this course, and we're really proud to do it this year in collaboration with the South Sudanese Orthopedic Trauma Society, the Ethiopian Society for Orthopedic Trauma, and of course the Hospital Universitaire Le Pays in Haiti. It's a great pleasure to have faculty from all three of those esteemed institutions with us today. My name is Kieran Agarwal-Harding. I'm the director of the Harvard Global Orthopedics Collaborative and course chair. Haley, do you mind going to the next slide? Thanks. So just for all of those who are joining us today, we have created a WhatsApp group where we will be sharing the lecture recordings that we do for these courses. We are sharing the live sessions like this one, the recordings from this, and also just a bunch of other resources that we think are very high yield and high quality. They're all free educational resources, so if you're interested, please join our WhatsApp group and participate in the conversation. We look forward to seeing you guys there. Next slide. So as I mentioned, this is week 2. Today's topic will be acetabular fractures, and we really have some excellent cases lined up for you today. Next slide. We just always need to do a quick reminder about Zoom etiquette. We do have the ability through Zoom to have closed captions as well as translated captions. So all of the conversation today will be in English, but if English is not your primary language, please do follow the instructions here to add closed captions in your language. There are many options provided by Zoom. So I'll just pause for 10 seconds to allow people to read these instructions and see if we can get that up and running. And I will also say that to engage in the conversation today, please use the raise hand feature, and feel free to use the Q&A. I'm getting a message here that people are having trouble hearing sound. Is everybody hearing me? Yeah? Okay. All right. Great. Next slide, please, Haley. So just to go over again, the course objectives for all of our courses, but particularly for this course on complex lower extremity trauma, are first and foremost to improve participants' knowledge of complex lower extremity trauma management principles. We do this through case-based discussion, but this conversation that we're having today, there's lots of work that goes into preparing for this. There are lectures that we record ahead of time. There are articles that we curate and select, and we've sent all of those out to all of you ahead of time. Just to participate fully in the course, we strongly encourage you to follow along with all those pre-recorded lectures and articles as well. And we really do hope to improve everybody's knowledge, whether you're a medical student, all the way up to a senior attending consultant. We hope that just the conversation itself really helps. Second of all, we hope to foster an international discussion regarding orthopedic trauma care delivery. We have so many amazing faculty members with us today and people from all over the world. And I think the real value of these conversations is really to understand the challenges in each of our practice settings, and also the amazing solutions that you guys all come up with in order to take fantastic care of your patients. And then the third objective, of course, is to motivate and support the younger generation of orthopedic surgeons, represented today by Dr. Haley Daniel, who's our chief resident at Harvard in our orthopedic program here and going into trauma. Next slide, please, Haley. So as I said, my name is Kieran Agarwal-Harding. I'm an orthopedic trauma surgeon at Beth Israel Deaconess Medical Center and founder of the Harvard Global Orthopedics Collaborative. And with that, I'll hand it over to my esteemed colleague, Dr. Daniel.
Great. Thanks so much, Kieran, for that introduction. As Kieran said, I'm Haley Daniel. I'm one of the chief residents at the Harvard program in Boston. My co-resident, Sravia, who was on the call last week, couldn't be here today. She's actually in the operating room as we speak, but we'll be back next week. So I'll be moderating the session today. We'll be monitoring the chat, the Q&A as we go along and discuss some cases. So great to see a lot of familiar names and faces from last week, and welcome everyone who couldn't be here last week. So just a shout out to the HGOC and SONA organizing teams. They are really the bread and butter and help the operation run. So huge thank you to everyone on this slide here. So we have some great cases today from all over the world. Dr. Teshome will be presenting an acetabulum case, and Dr. Solomon, both from Ethiopia. They're two pretty big cases, and we went over time a little bit last week, so we're going to really focus on those two this week. But if we have some extra time at the end, we have Dr. Rodriguez from Boston, who has an additional case we can discuss. And again, we're joined by Dr. Sami Hailu and Dr. Ephraim Gebrahana as our case discussants, as well as Dr. Pierre-Marie Wole from Haiti. And from South Sudan, we have Dr. Mpor and Dr. Madison on the line as well. And then Dr. Rodriguez will serve as both a case presenter and a case discussant as faculty, and Dr. Wickstead also from here in Boston. So here's a quick rundown. We'll try and stay within these time parameters as much as possible, but last week we had some really, really great discussions. So if there are a lot of questions coming up, if a lot of people want to continue discussing, these are some loose guidelines, but we'll try to stay to them, roughly speaking. So without further ado, we're going to start our first case presentation from Dr. Teshome. So I will stop my share, and Dr. Teshome, go ahead and share your screen with the first case. Thank you so much.
Thank you. I'm Dr. Teshome, orthopedic trauma surgeon from Ethiopia, and I will be presenting a combined pelvic acetabular fracture with ipsilateral hip dislocation and intra-articular fragment and femur shaft fracture. And so starting from the history, a 35-year-old lady, she's a pedestrian hit by a truck, and immediately she's taken to a nearby hospital, and resuscitation and acute phase of management was done there, and she was having a dislocation on the right side of the hip, and reduction was attempted, and it was unsuccessful. And she's referred to our hospital on 6th day of the injury. And after arrival to our hospital, she's hemodynamically stable, and on physical examination, we found a superficial abrasion on the left side of the face, tenderness on the bilateral pelvic and right thigh, and the right lower extremity is internally rotated and shortened. Neurovascular structures are all intact, and the other system is normal. Blood workup, all blood workups, available blood workups are in normal range, and she came with a CT scan of the brain, chest, abdomen, and pelvis. The brain, chest, abdomen CT is normal. Imaging on X-ray, she has this pelvic X-ray and pelvic X-ray. On pelvic X-ray, starting with the posterior pelvic ring, there is a widening of the right SI joint and questionable widening on the left side as well. Otherwise, the iliac wing bilaterally it's intact, and L5 bilateral is intact. On the anterior cervical ring, iliopectineal line is disrupted here, and there is inferior ramus fracture on the right side, clearly dislocated hip, and ilioscaal line. It looks intact on this side, and clearly visible fragments on the acetabula. On the left side, she has birami fracture, as well as on the right side, there is femur shaft fracture. So with this, we sent her for, we saw the CT. She came with the CT, and on the CT scan, on an axial view, there is a bilateral SI joint widening, and on the left side, there is a zone 1 fracture of the sacrum. And on the coronal view, you can see the intra-articular fragment on the right side of the hip joint. And the sacral fracture is also visible. So on the axial CT, you can see the posterior wall fragment and the transverse with the posterior type of acetabular fracture as well. And this is the posterior column on the sagittal section. So this 3D. On the 3D, it's the fracture is visible here. And posteriorly, the posterior wall fracture is very low type, and this is the transverse component of the fracture. It starts high anteriorly and exits kind of vertical and exits posteriorly very low. So diagnosis, she has a couple of diagnoses with bilateral SI joint widening plus left zone 1 sacral fracture, right hip dislocation, irreducible. It was tried 2 times and it failed. And right transverse with posterior wall. It's infratectal type with a very low type of transverse component. Left birami fracture, intra-articular fragment, and right femur shaft fracture. So with this diagnosis, we plan to take her to the OR with on the next day, and we anticipated challenges. How can we go with the order of fixation? How can we reduce it easily? And should we do the surgery once or stage it? And well, it has complication risks. Short treatment, we plan to fix the femur first because the femur is moving, and we position her supine, and we closed, and we did a retrograde intramedullary nailing. So while we do the intramedullary nail, we inserted a shanz pin towards the neck to prevent rotation of the proximal fragment while we ream. After doing the intramedullary nail, we proceed to fix the right side of the SI joint. So we inserted to S1 and S2 SI screws, and at the same time, while she is in supine position, for this we opened the lateral window, so you can see both the SI joint reduction on the anatomic reduction of the SI joint, as well as the anterior column at the same time. So after doing the SI screw for the right side of SI disruption, we inserted anterior column screw percutaneously with the aid of pelvic reduction forceps. So since she has intra-articular fragment we left the joint still in dislocated position, and we reposition her to lateral position. And with the Coker-Langenbeck approach, we removed out the fragment, the intra-articular fragment, and we're able to reduce the femur shaft easily. And finally, we check for the stability, and it's found stable. So we left the posterior column fixation because it's stable and it's way down. And this immediate post-op X-ray, this is the AP. This is the outlet. And both the anterior column and the pelvic ring is reduced nicely, and the joint is concentric and round. This is the inlet view and femur shaft. So we put her on anticoagulant, on heparin until she is discharged from the ward. So for 5 days, and she continued with the rivaroxaban for 1 month, antibiotics for 24 hours, and full weight bearing was started at 12 weeks. This third month X-ray, and on there is no significant change. There is callus on the left biramid fracture site, and minimal callus on the femur. And we appointed her after 3 months. At 6 months, she came with the pain on the thigh and limping. And on X-ray, we diagnosed her a delayed healing on the femur shaft fracture. And this is after we removed out the distal screws for this sign nail. So this is for dynamization. Dynamization is done. And after 1 year, we appointed her after 6 months again, and after 1 year, this is the X-ray. All the fractures are healed, both the femur and the pelvis. And clinically, she has no pain and no complications seen so far, and this is a clinical picture. In summary, in combined pelvis acetabular injury, it's better to stabilize the pelvis first, and better advised to start posteriorly and come to anterior. And in combined ipsilateral hip dislocation and femur shaft fracture, reduction is very difficult. So stabilizing the femur first is advisable, and proceed with the reduction. Third point is the dynamization for delayed healing is advised. And questions? Thank you.
Thanks, Dr. Teshome. Do you mind going back to the original injury film just for the purposes of the conversation?
Sure.
Thank you. Yeah, K-Rod, you got your hand up?
I can't hear.
I think Dr. Rodriguez.
The first thing I was going to say is this is incredible work. Truly, you know, these are so difficult. Even just to decide how to start is difficult, you know, and for every argument you can come up to do one thing or the other, first you can come up with an alternative argument to do to do something different. And we struggle with this all the time. So first of all, I commend you on what a beautiful outcome you have. I was hoping you could come up to the picture that shows what's happening posteriorly, because in your final X-rays, I noticed I didn't notice any hardware posteriorly. So did you find there was no need to plate or do anything for that? I thought there was a posterior wall injury that was there. I was wondering how you managed that, or were those fragments just excised and the hip remained stable?
Yeah, on that same point, I was curious about that intra-articular fragment. Did you actually get into the capsule and fish that out, or how did you address all that?
So we position the patient in lateral position, and we scale approach where the piriformis is torn, already it's breached. We go through it and we removed, it's a single fragment and we removed it out. So regarding the posterior column and wall, it's very low, as you see on the 3D. The posterior wall is very low, and the column it's kind of vertical. The exit is low on the E shape. So we neglect to fix it.
That's a good choice. So the fragment that I was confused because it looks like there's a higher posterior, but there wasn't. The posterior wall was mostly intact then, thankfully.
Yeah, almost intact. Yeah, it's very low.
Great, fantastic.
So just a quick question, and please, any of the faculty answer this. Not being a pelvic and acetabular surgeon, perhaps it's a silly question, but the hip was so unstable before that you couldn't hold a reduction. But then once you were able to fix the posterior column, then it was stable. Can you explain a little bit why what conferred the stability just by fixing the one column? Was it just escaping through the column fracture? Is that what was happening?
No, I would imagine it was hard to reduce because there was a femoral shaft fracture, right?
Oh, so it was just impossible to reduce. Is that what you mean, Dr. Teshome?
So, sorry, reduction was difficult because of two things. One, she has a femur shaft fracture, and the other pelvic ring injury at the same side. So if you apply traction, it doesn't transfer to the joint directly.
I see. All right. So, but once you got that head into the acetabulum, it was stable.
So, sorry, Rada?
Once you managed to get stability of the femur and stability of the pelvis, and then you reduced the hip joint, then it was stable.
Yeah. So we stabilize the femur first, and then the pelvis. Then we proceed to the acetabulum.
So an important detail, Kieran, is that this was dislocated for 6 days before it was transferred, right? So when you're dealing with a dislocation that's 6 days old with a femoral shaft fracture, the hope of reducing it in a close manner is kind of hopeless. So it's just a matter of what you do. So fixing the femur first in order to be able to control the hip is very reasonable. You know, this is great. If I was to suggest an alternative path, I think for the same reason that it's difficult to reduce the hip, it's also difficult to apply any traction to the sacroiliac dissociation, right? So I think doing an open exposure to actually put your hand there and feel it is very wise, and that's excellent. And that was a good first step. Yeah, you know, I think because you have to go laterally anyway to get that entrapped piece and take a look at what's going on in the back. You could have also done your cochlear exposure, right, as an alternative path, and then done an antegrade nail at the same time that you are dealing with the acetabular issue. You could manipulate now directly the proximal part of the femur, get your reduction, and do an antegrade nail all at the same time. But you know, this worked out beautifully. There's nothing to criticize at all. It was fantastic.
Any comments from any of the other faculty members? Yeah, Brian, go ahead.
Yeah, Teshome, that's a great case, and you actually did a lot of work in I think you did it in one session, if I'm not mistaken, fixing the femur shaft and stabilizing the posterior ring, and as well as going for the anterior column. It's really commendable work. I'm just wondering, for the left side, so you fix a sacroiliac joint posteriorly, but you still have the ring a little bit unstable in the front. What made you decide not to try to go for a second maybe surgery and fix that anterior ring?
So we thought that we have adequate fixation posteriorly, was right and left side of the SI joint. So we left for the left anterior biramide fracture without fixing it. Without it's stable enough, fixing the posterior.
Okay.
What weight-bearing recommendations did you make immediately post-op for this patient?
So she was totally non-weight bearing for 2 months, and we allowed her to partially weight bearing after 2 months, and full weight bearing was started at 3 months.
Good.
Dr. Woolley, go ahead. Question.
Yeah, first of all, I just want to commend you for a tremendous great case. This is a hard one anywhere. And I like your approach on kind of fixing the femur first. Any thoughts on you or any member of the faculty on putting that shunt spin into the femoral neck without necessarily, because we've talked about reducing the femur first to help with traction, right? But anybody would done this differently, not doing traction and just not like maybe not fixing the femur and then have more leeway to reduce that femoral head or not? I'm just curious.
Oh no! My suggestion was to do it all. So to do the supine iliosacral stabilization.
Yeah.
Then go lateral without doing the femur, right?
Yeah.
And put the shunt spins in the proximal femur, achieve your reduction, assess the nature of what's going on in the posterior wall, and then do an anterograde nail since you're there already.
Yeah. Yeah.
An anterograde lateral nail. Yeah.
Yeah, I completely agree. It's one of these things. We talked about this last week as well. Like if you have like a interstroke or some sort of femur fracture associated, if you put your shunt spin into that femoral neck, right, and it's not fixed, the femur is not fixed, then you have some leeway. It's actually easier. I've done this once or twice. It's easier to reduce once you follow that protocol. But it's just things that are, not everybody would agree with that, but it's just a way to kind of think about it. My other question for you is, how did I see that you put a reduction of the anterior column. Did you do it to the same approach, so lateral window, or did you do something differently to reduce that before putting that screw?
It's the same approach with the lateral window, was for SI and the anterior column.
Okay, perfect.
And regarding reducing with Shan's pin, I remember she has the same side SI joint injury.
Yeah.
So the SI joint will move more when you apply traction.
Yeah, I agree.
No, Pierre, I think fixing the SI joint first is the right thing to do, because you need something to build on. You need a stability, something to build on. So I was thinking of doing the femur and the acetabular posterior assessment and at the same time for another reason that came up in the last discussion. And thankfully we had a CT that kind of confirmed there was no occult femoral neck fracture. But you know what? I have missed them even with the CT showing nothing. So one advantage of doing an antegrade nail is you could have locked it into the neck and head to kind of address that possibility at the same time that you're reducing the head, fixing the femur, and addressing any issues with the posterior wall.
The only issue I will bring up with that, K-Rod, is that a lot of the time we're using non-cephalomedullary nails because we don't have them available.
Oh, I get it.
You'll notice here a sign nail was used, and generally speaking, we have sign nails available, and so we don't have that cephalomedullary construct. So going antegrade, retrograde wouldn't have made much of a difference on that one.
Yeah,
Okay.
but to add to that, you could always do a sine nail, a hip construct that we actually wrote up and published on that, where you could, and the same approach that Dr. Rodriguez mentioned, get 1 or 2 compression screws interior to that neck, and kind of build a construct if you don't have a gamma nail or some type of circular measuring nail as well. So the approach is possible. It's just that's going to be a little bit more, technically challenging, and then you just got to put 1 or 2 screws before doing any female fixation.
And one other possible advantage of doing a lateral nail in this case, whether you use a cephalomedullary device or not, is that it's hard to gauge rotation when the hip is dislocated because it's kind of floating around a lot, right? And I think the shunt spin to kind of control it was very useful. But if you're doing it on a lateral exposure, you kind of have a sense for where the neck is going. You can put your shunt spin parallel to the neck, and that could be your guideline to determine the version, and then you just rotate the distal part of the femur to match, and you have a little bit more reliability on assessing the rotation, so you don't have to correct it later on if it's a bit off. This is, it's so easy to offer better options or alternative options. You have to be there, It's a remarkably good outcome.
But truly a remarkable outcome, Dr. Teshome. I mean, just seeing the patient being able to squat like that is really amazing. But I think that the learning point here generally, both from Pierre-Marie and from Dr. Teshome's case, is that like you have, and what I have learned is you need to be able to control the proximal femur, whether you do a nail to control the fracture of the femoral shaft, and that gives you control, or you just put the shank pin into the femoral neck and use that as a joystick before you fix the femur. Either way, you need to get that control, and you can only get the hip reduced once you've built from the SI joint and stabilized the pelvis. So that's a learning point for sure that I will keep, and I really appreciate that from both Pierre-Marie and from Dr. Teshome. Dr. Hailu, Sami, I see that you wanted to say.
Yeah, so three learning points here really. One of the things is sequencing. When you look at the details of the sequencing, you have to stabilize the pelvis as well as the femur before you even consider reducing the hip. So in that case, the single position that you can do both at the same time is if you keep the patient supine. So it only makes sense to do retrograde nailing as well as SI joint at the same SI fixation at the same time. And the other point is, if you consider doing antegrade nailing, it becomes a little bit more challenging to assess rotation in a lateral position as opposed to supine position, where you can actually, put your screw in both distally and proximally and actually check, your internal and external rotation and compare it with the contralateral side, which you cannot easily do in an antegrade nailing. So in a simpler setup, it is just much easier to do, fixation of the femur first. Then you can, manipulate some of the pelvis to get SI screws. And then, you can, once you have a good stable pelvis and femur, you can actually reduce the hip joint. And then, you can either reduce the hip joint or do the acetabulum and consider doing, it is interchangeable. You can either first reduce the hip or fix the acetabulum, and then that's the kind of thing. But doing the femur retrograde in supine position gives you multiple advantages in this scenario. So the other thing is leaving the posterior wall slash column fracture. It reiterates the fact that the rule of thumb when you consider or even do measurement of roof arc. There are 2 contraindications, right? Well, I guess 3 contraindications whenever you consider the stable roof arc in whenever you consider non-operative management of any acetabulum fracture. That is, if you have a posterior wall fracture, you don't consider measuring roof arc. And the other is if you have, unassociated both column and acetabulum fracture, you don't consider, looking into whether the roof arc is stable or not. And the third one is if you don't have any congruent acetabulum, right? Hip joint. If the hip joint is not congruent, you don't do you don't consider roof arc measurement. And non-operative treatment will be basically out of the picture. But in this specific case, this rule doesn't really consider the position of the posterior wall. But in this specific case, the posterior wall fracture is really low enough that it will significantly affect the stability of the hip joint. So leaving it alone is another good, learning point, that you don't necessarily need to fix. You don't necessarily need to follow the rule of thumb that says, whenever you have a posterior wall fracture, you should check. You cannot check a stable roof arc rule, basically. So the third thing that I would like to talk about is, doing less is always more, especially in cases where you have multiple fractures like this one. Leaving the contralateral pubic body versus rami fracture, that only makes sense. If you assess, if you have good posterior pelvic fixation and check the stability of the pelvis, and if it remains stable, and if you don't have any movement on the anterior ring, you don't necessarily need to fix it, right? So that's another doing less is more. You don't necessarily. This is a well vascularized area, and you are not going to allow the patient to wait there anyways. It only makes sense to leave it alone and not do unnecessary exposure and prolong the surgery at the same time. So doing less in this specific case is single screw doing the anterior column fixation and leaving the posterior wall alone and leaving the left rami versus pubic body fracture. So it's really a well thought surgical thought process. So that's what I understand. Thank you, Kiran. Back to you.
Thanks, Eric. Great points. Yeah, Kiran.
There's a good question in the chat regarding the risk of a vascular necrosis, which obviously is very high in this patient for several reasons. First, the nature of the dislocation, that it was unreduced for 6 days, and the effort and pulling and messing that it took to kind of get it reduced. It certainly increases the risk of a vascular necrosis. Thankfully, we have a 1-year follow-up, and there doesn't seem to be anything very obvious in terms of AVN. But I would question, how long would you follow this patient for to make sure that they are free of that risk? And I usually tell my patients, I need to see you up to 2 years. If by 2 years you don't have a vascular necrosis, then we are probably have a bit of a better situation. But you're at high risk up to 2 years out.
Ryan, what are your thoughts on that? Because you probably in South Sudan see a lot of patients coming delayed with hip dislocations and acetabular wall fractures, posterior wall fractures.
Yeah. So this is quite a big problem here. So most of them actually come with dislocations late. We see some of them maybe 2 months or so after injury. And for those pure dislocations, we just take our chances, try to do close reduction, but actually the risk for a vascular necrosis is quite high, because when you follow them up, most of them actually develop a vascular necrosis. I think that's just the trend everywhere.
There's another really good question, a few questions actually on this topic in the chat, relating to the femoral shaft fracture. So I don't know if maybe I'm just seeing it on the X-ray, but it looks like it may have been segmental. There's like a sort of subtrope component and then a femoral shaft component. Am I just not seeing that right? It looks like there, yeah. So it was a segmental fracture, it seems, which all the more explains why this was so difficult to control. So the question in the chat is dynamization. You chose, Dr. Teshome, to dynamize the nail at 3 months because you were suspecting a delayed union. I totally agree with you. This looks like it's going on to a delayed union. There's an oblique fracture plane, and all the stress is probably just in that plane, and it won't heal. But you jumped on this early. At 3 months, you dynamized it. And one of the questions, was why the screws were removed. So that's why, to dynamize and create, more strain there to allow for healing. And obviously it was the right decision. But can you talk a little bit about, why you chose to do this at 3 months instead of waiting, what you were thinking?
We dynamize at 6 months, not 3 months. So at 6 months, we expect healing from the femur, and there is no much progress that's in between 3 months and 6 months. So the dynamization is done at 6 months.
Gotcha. Okay, that makes much more sense. Yeah. Sorry, I didn't see that slide. Great, thanks. Okay, I think the other questions in the chat that are relevant here, Dr. Milkias, who gave a great presentation last week, asked a question about the superior ramus screw, like the screw that you used. I think that was for the posterior column. Is that right? Can you talk a little bit about length of the screw, what you were trying to achieve there? Walk us through that a little bit.
So once we fix the pelvis, the femur and the pelvis, percutaneously we did with the mini opening, we did the anterior column screw. And reduction, we can, since we open the lateral window, it is easy to put the reduction forceps and see the reduction as well. Did I answer the question?
Dr. Milkias, if you're there, maybe you could ask the question yourself to see if that's clear.
I think Milkias is worried about the posterior wall fracture. He says you can still see the fracture on the control X-ray. But as I alluded to it earlier, even on your follow-up, you can see the posterior wall fracture. It is actually outside the zone of the stable roof arc. So it just doesn't make any difference, whether the fracture is actually, displaced or even if it doesn't heal, it doesn't make any difference when you consider it and you look into the outcome of the patient, because it's way out of the zone of the stable roof arc, and as long as it doesn't affect the range of motion and as long as the hip remains stable, it doesn't make sense. It doesn't make that big of a difference in a way.
Yeah, thank you so much, Sami, and thank you, Teshome. It was a very excellent job. So, yeah, my question was regarding the length of the anterior column screw. I mean, if you are putting it in antegrade fashion, and then how long should the screw go? I mean, definitely you have already the access and you are inserting the screw, so you need to anchor it in a very good bone stock. So if we see it here, it's kind of ending in the superior rami, mid of the superior rami. So it's a nice job still, but I just want to emphasize that the superior rami screw probably would have a good anchor if it is traversing all the way down to the parasymphysial area of the bone. That's my point, Shami. Thank you.
Thank
sorry,
you.
Mike. I just saw that you have two different questions. Go ahead, Teshome.
Thank you. So regarding the anterior column screw, as long as the anatomy of the superior ramus allows, it's better to have good adequate length. But the length we could get is this one. It might be a bit higher. Our starting point may be a bit higher. So that might be the reason. But using a long enough screw is still advisable. Takes a message.
Yeah, I think
Is there any bias? Go ahead, Brian.
Go ahead. Yeah. So I think because he was there, so regarding the exposure, that's why I decided to put this the anti-grade screw. But of course, length is a problem. The anterior column fracture is just very close to the tip of the screw. So we discussed last time about retrograde anterior column screw, which could actually be helpful in this situation, or even much better if you had the chance to do a stopper approach, to put a long plate, a brim plate, a smiley plate, that can actually cross the symphysis pubis to fix the contralateral superior fracture. Yeah.
Yeah, thank you so much. And the other question would be probably to the faculty. We still can see the inferior part of the posterior wall is still there. On the second picture that we can see it hanging up. I don't know, probably Dr. Teshome has removed probably another fragment, but this fragment of wall is still there. So either Dr. Teshome or the faculties, would you go for fixation of such low posterior wall fragments as long as you have already an access with the KL approach? Do you think that it would play a role of instability whenever patient, let's say, when more than 90 degree of hip flexion is there? So once you have an access, would you fix that separate part of posterior inferior wall fragment? Thank you.
So, Mike, we didn't remove any fragment, and Sami was answering this question that you were there. So the posterior wall is very low and it's small, so it doesn't affect the stability of the hip. And Sami was saying doing less is more for this multiple fracture.
We have one question just quickly from the chat about the size of that anterior column screw, not the length, but the actual width of the screw. Do you remember what size screw that was?
It's 6.5.
6.5. Okay, thank you.
Yeah.
Dr. K-Rod, you have your hand up.
Yes, I was going to comment on the question regarding the inferior part of the posterior wall. I agree with Dr. Teshome. You don't need it from the stability perspective. You know, if you're there and working on you could put a screw just to reattach it so that it doesn't create a non-union plane in the future or anything like that. But there's no mechanical reason to stabilize it. And the only reason I wouldn't excise it is because it's attached to a little chunk of the ischium. If it was just the articular part, I would have tossed that away and not worried about it.
Could I bring up a question that's shown up in the chat that I feel like as a non-pelvic acetabular surgeon, it would be helpful for me to know actually. The question is, how do you preserve the blood supply to the femoral head? I mean, of course, the cat's sort of out of the bag at this point. The head's being dislocated for 6 days, multiple reduction attempts. It's a tough situation, so the risk is very high. But are there considerations, Dr. Teshome and any of the other faculty, when you're doing that posterior approach and trying to get the hip reduced? Are there considerations you take for trying to preserve the femoral head vascular supply? And could you share those with us?
I mean, I'll just jump in this one. If Dr. Teshome wants to do it first, go ahead. If not,
go ahead.
So I'll just jump in. The mechanism of injury by itself, with that dislocation, by definition, you have disruption of the vessels, right? I mean, most likely. Gons has the original paper that describes, his Z capsulotomy to dislocate if you have intracapsular fragments and stuff like that. And even in his paper, you can see that those vessels are really posterior. And if you got that mechanism of dislocation, those vessels are technically gone. So I think that the cat's kind of out of the bag in that sense. I don't know if anybody else has a better idea on vessel disruption. But I feel like if you have such a dislocation for such a long time, I would be worried about 2 things. The vessels being, kinked or ruptured, and the sciatic nerve, which, if you have 6 days with that. I also didn't ask how is, the outcome is great, so I figured you didn't have any sciatic nerve issues or drop foot or anything like that. But any comments on that or thoughts?
So regarding the injury to the vessel, if it is injured, it's due to the trauma, and I don't think guns will help. It's an extensive procedure, and it doesn't.
No, I didn't
Oh.
mention. No. I mentioned the Gauss paper when it's not dislocated and you want to dislocate it. It's in this case it's already dislocated, so that was my thought.
And the sciatic nerve was intact pre-operation, and post-op it's intact.
When you do the approach, Dr. Teshome, do you visualize the sciatic nerve? I assume that you do.
Yes, it's not contused. It's like normal.
Okay.
No injury.
And I seem to remember from when I was a resident doing pediatric, like hip dislocations and stuff like that. Isn't there something like if you don't take down quadratus, the blood supply to the femoral head should be preserved or something? Haley, do you remember? Can you talk a little bit about that? Do you remember that?
Yeah, I mean, usually that's the extent of it should be the extent of your exposure with the Coker. But obviously, yeah, like it was mentioned, there's certainly a high risk of of injury just from the trauma to the blood vessels. But yeah, I think that's usually what they teach us is you stop your distal exposure at quadratus, and typically that preserves the blood supply to the head. And then one question I had, just with regards to the sciatic nerve, obviously she was okay here, but how if she came in with a foot drop or sciatic nerve palsy, are we just managing that typically expectantly? Are you just giving the patient an AFO and seeing how they do, or because this, obviously she was high risk, but if any of the faculty have any thoughts on that.
Sami, are you there?
Yeah, sure. No, Kane has raised his hand, so I wanted to give this.
I was going to comment on the vascular issue. I was going to say that at this point, you're absolutely right. 6 days dislocated. There's probably not much you can do other than lighting a candle to your preferred deity. But essentially, the issue is whatever you're going to do is going to make things better, right? So the most important thing you can do is a prompt reduction to preserve vascularity. And I happen at the risk of being excommunicated from the community of hip surgeons. I've never really bought into the dogma of how the perfusion of the femoral head is. I happen to think that in younger patients, the feeding of the vascularity from the foveal artery is more important, but sadly that's also disrupted here. So I think this patient has a very high risk of AVN and should be monitored carefully because of the dislocation and because of the extended duration of the shortened dislocation, that even with an intact quadratus puts a lot of tension on that branch of the circumflex artery.
Yeah. So in regards to late presenting dislocations, there are obviously some uncharted territories in regards to who develops AVN and who doesn't. But in our review, one of the articles that you have seen in the shared program, in that review that we did, one of our findings is when we have late presenting femoral head dislocations with a posterior wall fracture, somehow the blood supply seems to do better as opposed to when you have a pure hip dislocation. And one of the things that might contribute to reasonably preserved blood supply could be the fact that the capsular attachment with the wall might go along with it, and hence the blood supply might still remain there, and the kinking would be might potentially be minimized with the wall going along with the capsule. And one of the critical things that we should never do is obviously excise or separate the capsule off of the wall fragment. So whenever we elevate, we keep the capsule along with the fragment of the posterior wall. And obviously, the other thing that we do, as Haley and the others mentioned earlier, we preserve the quadratus, and if you have to detach the quadratus for any further exposure, we detach it not from the insertion, but rather from the origin, because blood supply goes around the insertion of the quadratus femoris. and obviously, detaching the short external rotators like the triceps coxae and the piriformis, 1.5 centimeter, leaving half of tissue. That is also the other way to minimize the blood supply to the head. And the other thing raised is, what if there was an associated sciatic nerve palsy, right? The typical thing that we would do is neurolysis of the sciatic nerve. That might not be a guarantee for its recovery, but that's basically what we did. And if there is an obvious fragment that was basically, strangulating the sciatic nerve and, alleviating that pressure, definitely helps us. I have seen a sciatic nerve recover now 2 years after the injury. And it can recover even long term when you have a transient injury, and obviously if you have a complete transaction, that might be a different ball game. Back to you.
So forgive the upper extremity surgeon here bringing in upper extremity to this, but like if it's like in a humeral shaft fracture where you have a radial nerve palsy, do you wait 6 months to see if there's functional recovery? And if there's not, then you go back and you explore? Is that similar to what you would do with a sciatic nerve? Wait 6 months?
No, not really, Kiran. It will be too late by the time 6 months has passed.
Okay.
If you want to do anything, do it early. I don't think there is any point in waiting in sciatic nerve. And obviously, when there is a palsy there, something must have gone wrong. It's either a dislocation or a fracture that is impinging onto the nerve. I don't think it's a worthwhile endeavor to wait 6 months when it comes to sciatic nerve palsy.
Great, thank you. Haley, I don't know how you feel, but I think we should leave some time for Dr. Solomon to give his excellent case presentation. Maybe we should move on to that one. Dr. Teshome, superb case, really amazing discussion as well. Thank you to all the faculty. Dr. Solomon, you next?
Yeah, I'm here. Okay. Okay, hello everyone. Welcome to the virtual scientific conference on acetabular fracture case. So I'm Dr. Solomon, orthopedic trauma fellow from Addis Ababa Black Line Hospital, Ethiopia. So I'm going to present some case. So the first case is a 49-year-old young man. He's a farmer from the countryside. He was involved in a collision while he was riding a cart. Then he injured his left pelvic region. So this was an isolated injury. On physical examination, the vital sign was in the normal range. So he had proximal tibial skeletal traction when he referred to us. Actually, they keep him there in the nearby hospital for 1 week. And then they referred him finally after 1 week of the injury. So when he came, he had proximal tibial skeletal traction. Otherwise, the distal neurovascular structure were intact, and the soft tissue condition over the pelvic region was fine. He had only just complained pain over the left pelvic region. So this was a pelvic AP X-ray. Total duration until we took him to the operation theater was about 2 weeks. So this was AP pelvic X-ray. So here a trend is when we comment on pelvic X-ray, we usually start from the posterior. So we have to look for the transverse process of L5 on both sides, and then we have to look the whole sacrum, so as well as bilateral side joints. Then we need to see the acute lines of the sacrum on both sides. They have to be continuous as well as symmetrical. So in this case, both the transverse process are intact. The acute lines of the sacrum is fine, and then the side joint looks more or less comparable and fine. Then in addition, we have to look for the iliac crest starting from the posterior superior iliac spine onto the anterior inferior iliac spine, and then on both sides, and then finally we'll come to the acetabulum evaluation. So there are 6 cardinal lines we need to see on the pelvic AP X-ray when we evaluate in patient with acetabulum fracture. So as you can see from this X-ray, the iliopectineal, when we follow this black line, so the iliopectineal line is disrupted, the ilioscale line is as well disrupted here, and then the the posterior rim as well as the anterior rims are disrupted at single point. And then the teardrop is a bit medialized. The whole femur head is medialized. Then in addition, if you see there is, I'm not sure whether it's visible for you, but there is a condensed impacted structure visible. So we have to look for the roof. So there is a sort of impaction. So with this pelvic X-ray, I have a question for the faculty. So do we need Judate views? We have CT scan for this patient. So do usually order Judate views? Maybe one of the faculty. Dr. Brian.
Absolutely, Solomon. I think Judate views are very, very important. I know from the AP view, you can see the iliopectineal and ilioischial line, they're disrupted. And you can somehow observe the anterior and posterior wall, but Judate views really give you a lot of valuable information that sometimes in setting like ours, which is resource limited setting, sometimes we just, Judate view give us enough information, especially if the patient does not have access to CT scan. So I do order it routinely, but the problem is most radiographers don't know how to do it.
Okay, thank you, Dr. Brian. So I raised this question because there are some noises from experts. So if we really going to have a CT scan, what's the need to expose the patients for additional radiation, for additional costs, as well as it's a bit not comfortable the patient to take an acute fracture. So what is your comment, Dr. King?
I would offer a few other questions. If you only have access to plain films, you will need more images in this particular case, not only to define the fracture a bit better, but I'm looking at this and I think the diameter of the left head is a little smaller than the right. So I would worry about there being a dislocation here that's not showing very well. Now, the fracture pattern, this kind of transverse looking fracture pattern doesn't suggest there will be a dislocation, but I've seen cases where the acetabular fracture does not look very displaced, yet the head is completely lying behind the pelvis. So that's one little concern I would have, particularly if the patient is not going to receive care immediately. If the patient has to be transferred somewhere at a distance, and there's going to be a few days delay in care, make sure the hip is not dislocated.
Okay, thank you, Dr. Ken. So for the same reason here, we usually order a Judate view because there are some setup where CT scan is not available, and there are some fracture which can even that doesn't need CT scan because although they have a stable fracture, when we see on different views, they may not really have fracture. The other reason is so we fellow as well as residents, we need to learn from diagnosing acetabular fracture with Judate view. So for the same reason, we usually tend to have Judate view. Unfortunately, I couldn't access his Judate view X-ray here. So he has also CT scan. So this picture shows, this slide shows the axial CT scan starting from higher up, from left side to right side. So as you can see from the first picture, so the fracture started here. So there is involvement of the pelvic brim that represents anterior column. On the second picture as well, there is involvement of the extent of displacement to the anterior column is increasing, and then as you can see from the yellow, the light blue arrow, that represents the quadrilateral plate involvement as well. And then the white arrow also shows the fracture also exists to the anterior, the anterior rim is also involved. And then so the green, as you can see from this axial slice, this green arrow shows there is a problem with the portion of the dome. So the dome is not, there is a gap as well as it seems it's hinged over here. So that's the side where the supraumbilical impaction. Then the purple arrow also shows the involvement of the posterior column is a bit lower down. And then the red arrow next shows the involvement of the superior pubic ramus, and then as well as the inferior pubic ramus. So this slide also shows the coronal slices, as you can see from this picture. So the red arrow shows where from anterior to posterior, the anterior column is involved here, On the second picture, the extent of displacement to the anterior column is increasing. And third picture, clearly the impaction is visible on this picture, as well as so as you can see from the other picture, where the red arrow shows the impacted part, and then the blue arrow shows the portions of the QP. And then the last picture, the level of the posterior column is involved. So this is a 3D rendered picture. So from this fracture pattern, what do you think what type of fracture is it from the faculty? Okay.
It's an anterior column, posterior hemitransverse type of thing.
So yeah, that's what we initially considered. So but if you see the fracture pattern, so the primary fracture is starting from here, and then it goes to the anterior column. But when we see the picture from inner aspect of the pelvis, it has some features of the transverse, I mean the T-type, but there are the fracture patterns, like the head follows the anterior column. The extent of displacement over the anterior column is more higher than that of the posterior column. And then the presence of impaction, as you can see from this, this is a site where the impactions occur. So all these things will in favor of the anterior with posterior hem transverse acetabular fracture. So with this diagnosis of anterior with posterior hem transverse acetabular fracture, so our surgical tactic was position. The patient was in supine position with this fracture pattern. So our surgical approach was, I took this picture from Dr. Saj paper. So we use both the lateral window as well as the fan steel incision. So with the lateral window, whenever we plan to do a dual approach, the lateral window along with the fan steel incision, we usually start from the lateral window for a lot of reasons. First thing is, after we detach the external abdominal muscle, we usually put a pack over there. The pack will do a lot of jobs. First thing is, will help us with dissection. Second thing, will help us to secure hemostasis. So we left it there after we put the the pack, and then we'll come to the fan steel incision. So initially we opened the lateral window. Because the fracture was a bit delayed. We took him to the OR after 2 weeks of the injury. So to remove soft callus over here is a bit difficult from anterior, unless you have a sort of a special curved curate, but it's going to be easy removing the soft callus from the lateral window. And then we also plan to put a column screw for the posterior. That's why we open the lateral window. Otherwise, in most of our fractures, we're able to fix most of anterior fractures from the AIP. So with this approach, then I took also this picture from the Dr. Site paper. So whenever coronal mortis is very small, so we usually coagulate it. Or if we found it's large, we usually ligate it, and then we put a sharp Homan. Once we elevate the portions, the anterior portions of the rectus abdominis, we put a sharp Homan here, and then once we cut the iliopectinal fascia over here, then we usually put so this instrument is, so then this instrument will help us holding the external iliac vessels along with that of the iliacus, so we can able to play with fractures over here. So as I have told you, as you see, as you have seen on the X-ray as well as on the C scan, so this patient has a sort of supraradial impaction. So whenever you have sort of impaction in such type of fracture, I mean, it's quite common to have sort of supraradial impaction in patients with APH acetabulum fracture. So what's your technique for reduction? So, I mean, disimpaction, elevation of such impacted fragments, Dr. Brian? Or maybe another faculty?
Oh,
Yeah,
reducing.
yeah. Go ahead, Ken.
Go ahead.
That's
Karen Murray, go ahead.
Yeah, so there are a couple ways you could do it if because you did a stop approach in a lateral window, basically, kind of expose that anterior column. So there are a couple of things you could do. One thing you could do is, get a shunt spin on the iliac wing or anywhere, because there are two things you could do with that iliac wing. You could put shunt spin on the iliac wing, and it could use for two things. Kind of do that rotation and kind of to reduce it on that point, or use an external fixator, because you have your head impacted as well. Remember that, right? So the head, as you showed on your plain X-ray, it's kind of engaging into that surface. So just by pulling that head out, and you can hold that with an external fixator temporarily, you should get motion for that. And then one thing I've done is kind of put, when you're putting that retrograde screw, if you're doing a stopper approach towards that iliac wing, you can actually use, if it's a big screw, if you're disimpacted, that motion is easy. My issue with this case is delayed. That's what you mentioned, right? Is it delayed?
Yeah, it was 2 weeks.
Yeah, that's hard, and sometimes you have to use a distractor and stuff like that, or use a middle window to kind of see what you could do. So that's a hard case.
Karen Murray, can you describe
Right.
how you would use the distractor? Like, how do you put that on and how do you use it?
Yeah, it's basically it's like you're putting a shunt spins into a iliac wing if you're doing a closing with an external fixator, and then you put pins into the femoral shaft, and then you kind of have abduction and traction on it, and the distractor kind of holds that head out. So let's say it would be the equivalent of a resident or somebody holding a shunt spin, pulling the head out. It's just that you don't have to necessarily have a third assistant doing that.
I see. So between
And
the
it also help you control your rotation. If you have
Gotcha. So
Yeah.
that crest to the femoral neck, that's where you're doing it. Gotcha.
Yeah.
Thanks.
Okay, so
Yeah,
what
I think
we
just to add on Dr. Woolley's point, I think putting on a shunt spin on that on the femur, on the neck, and pulling out actually helps you a lot with the disimpaction. As you can see that the head is a little bit medialized, so pulling out helps you with that impacted fragment. But again, since you're doing a stopos approach, it actually gives you excellent exposure to the quadrilateral plate, so you can actually do direct reduction from through your stopos approach.
okay, so the elevation
Just
of
one thing I would
the
add.
super.
Yeah, just to
Okay,
continue
Dr.
what
Neil.
Ryan said before we continue, is you could also do an ASIS osteotomy, right, on your lateral window, because you already have a lateral window open, right? And you can do an
Yeah.
ASIS osteotomy, and that gives you way more exposure going to that anterior column.
So the supraumbilical impaction. We usually start whenever we have such type of medialized acetabulum. We usually start with putting the shunt spin just below the subvastus ridge to the femur neck. So that will help us to lateralize the femur head. That's once we lateralize the femur head, we are able to access the fracture. So there are a lot of techniques. I mein, there's a direct technique as well as indirect technique for elevation of an impacted fragment. Here we use an indirect technique. We use a direct technique. The direct technique is, so we use the AIP approach. So the fracture was really visible. So we were able to access that impacted fragments through this fracture line. Then once we access that, we use a osteotome from AIP approach. So we are able to disimpact that fragments. And then once we disimpact that fragment, we put temporal K wires holding the disimpaction at its level. And then maybe a comment from the faculty. Whenever you try to reduce an impacted fragment, do you try to over reduce it using the femur head as a template, or just you try to achieve just anatomic? Because it's quite common to achieve reduction as well as it's quite common to lose reduction after the superumbilical impaction is disimpacted.
So over reducing it would make more sense because it's going to collapse back to what the femoral head wants it to be. I would just say this is exceedingly hard to do when the fracture is fresh, and it shows a higher order of skill to do this when after 6-7 days. I think when you're working from the stoppa window, the little circle in red that you have there shows why this is hard, because universally there's always a little extension of the distal half of the anterior column that kind of covers your gap. So actually looking into the joint and seeing where these pieces are is very hard, and it gets even harder when the patients get kind of bigger and fatter, right? So looking at this from above makes a little bit more sense. So putting an acetome and being able to see enough that you can reduce this effectively is really hard and very rare. So most of the time, what I end up doing is retracting the femoral head, making room, trying to reduce the pieces, right, to a slightly better position, right, releasing the femoral head to allow it to mold a little bit, and then either instrument on top of that, and if you have room for bone graft, to do that. But it's really hard to address the impaction in this particular case.
Dr. Teshome brought up an interesting point of putting in like a laminar spreader into the fracture site and trying to look into the joint that way. Dr. Teshome, do you want to make a comment? Okay, all right, that's fine. Go ahead, Dr. Solomon, continue.
Okay, so as you see from this right circle, so the fracture is just open up, so it was really easy to access that impacted fragment. So as you can see from this intraop CRM image, where we use osteotome just behind the impacted fragment, and we try to disimpact it, and then after we disimpact, we put a temporary wire there. Then after temporary wire, we took so in our setup, bone substitute is not available, so usually we use autologous bone grafts. So we took that bone graft from the anterior portion of the iliac crest, and then we put it there, and then we hold it with temporal wire. Then after that, so we finally put a buttress plate, suprapectineal buttress plate, that buttress the anterior column. Initially, we hold this column with a temporary wire. Then after that, we put a suprapectineal plate. We put, in addition to that, the patient had also a sort of parasymphyseal fracture over here. So not this case, but so we put a suprapectineal buttress plate. Then once we took the graft from the anterior portion of the iliac crest, we put it just behind the impacted fragment. Then this QP segment was flipped, and then we put it back to there, and then we hold it with an independent screw. And then after that, we put a posterior column and antegrade cannulated 6.5 millimeter cannulated screw with help of alternative CRM images. So this was the control X-ray immediately. So then after that, we put him on rivaroxaban 10 milligram for 6 weeks. We usually tend to have a follow-up X-ray at 6 weeks, at 3 months, 6 months, and then 1 year. And then we don't allow them to wait before 3 months. So this was a control X-ray immediately. As you can see, the articular surface, the hip is so congruent, so it's clearly parallel. And then the articular surface is so smooth, and then it's well reconstructed, and in both Judate views. So this was a control X-ray.
Dr. Solomon, I
So,
think I may have missed this point. When you addressed the marginal impaction, did you have to put bone graft or anything to fill that void?
yeah, so we put a bone graft from the anterior portion of the iliac crest over here, and then we put it back just behind the disimpacted fragment. That's what we did.
Thanks. Sorry if I missed
And
that.
then, yeah, so and then we put an independent screw that drafts the disimpacted segment, as you can see from the picture. These two screws are independently holding the disimpacted fragment. This was a post-op X-ray. So we were able to achieve the articular reduction. The disimpacted part now looks fine. So do you order a post-op CT scan in your setup? And any comment from the faculty?
I mean, if you have access to a CT, that's really great work. I'm just curious, how long was this fracture again, you mentioned?
2 weeks.
2 weeks, right? So you're kind of in the borderline of doing this. And you see how you have to do your osteotome to kind of disimpact that. I would definitely order a CT scan if I can, just to kind of see what was done and if there were any issues. But that's really great work. In a very difficult pattern to kind of access. I guess my question for everybody would be, what would be your threshold not to fix these? And this is really important in low income settings, especially where the patient comes, like Brian said, in South Sudan, 2 months, 3 months. Like you've struggled after 2 weeks, right? So what would be your threshold to decide, well, this is gonna, we're gonna find a way to heal it and then get an arthroplasty at some point or some other kind of surgery? What's your threshold for that?
Sammy, any thoughts on that?
Yeah, so I think it is, you can't have no one answer for all in this sort of scenarios. You have to see things on case by case basis, basically. To start with, the expertise level that you have and how many of these delayed cases you have been able to successfully, address and with a good outcome is one thing that you have to see. But in the Western literature, in the Western practice, you see 3 weeks and you will not have a good outcome. But again, if you look into our paper, the average time is much more delayed, and we have operated patients as delayed as 6 months after the fracture. But it has to be case based, depending on the fracture pattern, the vascularity, the cartilage, assessment that you have from your cross-sectional imaging, and then obviously whether you can do anything better, and whether hip replacement is something easily available in your settings, right? So it is all multifactorial thing that you just can't say, no, do this and that. But to the most part, people say it is past 3 weeks, so, leave it alone and do hip replacement later on. That's not something that we can easily do in our settings as the resource is limited, and hip replacement is not something rarely available for all Ethiopians.
I agree.
Yes, you have your hand up.
Yeah, thank you so much. So it's a great job, Dr. Solomon, and thank you for your nice presentation, especially the impacted dome. So one thing you have raised is about making an osteotomy. So would you consider kind of opening a window and then disimpacting the impacted fragment with the window? Is one question. The other is, do you think it would have been accessible through the fracture site? That is another point regarding the dome. And other points to raise would be regarding your starting point for your posterior column screw. So where do you normally start your entry for your posterior column screw? That's the second one. And third one is when you put your supraacetabular, suprapectineal plate, I don't know, have you considered putting screws just passing the joint anteriorly? I mean, you have already put 2 screws on the parasymphysial area, but just to make it a little bit stable, could you have considered putting 2 screws posterior to those 2 parasymphysial screws, or probably, I don't know, if the plate is a little bit localized laterally, I'm not sure, but did you consider that? So these are my 3 points. So thank you. Thank you. The presentation was very nice. Otherwise, these are questions to you, or the other faculties probably could be involved as well. Thank you.
Okay, thank you, Dr. Milkias, for your nice comment. So, to start from the first question, so whenever there is an impaction, so we can able to access. It could be like directly or indirectly. So in our case, so we are able to access the fractures, the impacted segments through the fracture. As you can see from this picture, so the red ring, so the level of impaction was over here. So before just reducing the anterior column, it was open up, so we were able to access this one. Otherwise, when this fracture doesn't allow, so there is another technique. So yeah, so you can directly with help of CR, like what we did for proximal tibial plateau fracture. So we can do a sort of cortical window over the top of the dome, and then we can able to use some instruments to disimpact that one. That is one technique, but here we were able to achieve. I mean, we were able to access the impacted segment. That's why with direct access. Otherwise, if it is not available through your fracture line, creating a cortical window is another option.
Yeah, thank you. I had some connection problems, so probably I didn't hear you very well. So you accessed it through the already fractured side
fracture.
then.
Yeah.
Thank you.
Yeah.
All right.
So the second question, our starting point, unfortunately, our table is not radiolucent, so it's really tough to take a proper iliac oblique view and then obturator oblique view whenever we plan to put a posterior column screw. But our starting point is a bit lateral to the suprapectineal plates. On average, as written on a lot of papers, 2.5 centimeter away from the SI joints, anterior portion of SI joints, and 1 centimeter from the pelvic brim. That's the entry side we tried to use for this posterior column screw. Regarding the third question, so I mean, whenever if there is no any involvement of if there is no any involvement of the symphysis, or if there is no any fracture like parasymphysial fracture, I think 2 screw is enough to the superior portions of the ramus, and then posteriorly through the suprapectineal plate we put 3 screws. I think 2 to 3 screws is enough if we able to buttress the plate. That's my
okay.
comment. Any additional?
Yeah, did you use a J plate or a
A
180
sort
or
of plate. It's a sort
sorry?
of jet plate. Yeah.
Is it the J plate?
Yeah,
Yeah, so my
it's a
question,
jet.
yeah, I agree with putting 2 screws on the parasymphysial area, but my question was just posterior to the parasymphysial holes, probably on the third or fourth, probably fourth could be intra-articular. I mean, just to have a good compression on the anterior column. I mean, you are kind of spanning it a little bit longer. So my worry is anterior column fragment probably could be a little bit unstable, or once you have the access, putting more screws just near to the fracture site or near to the joint line would be probably would keep it a little bit more stable. That was my point. Otherwise,
Okay.
it looks like it's well stabilized. Thank you.
Yeah, thank you, Dr. Milkas, for your nice comment as well. So, as I've showed you on the CT scan, he has also a superior pubic ramus fracture over here. So, just putting the third screw over that would be a site for a fracture. But we try to get a longer parasymphysial screw. Otherwise, I agree with your comment.
Okay. Thank you.
I think it is important to note a couple of things. One is, in regards to putting a screw, it's basically, you call it basically, infra-acetabular screw, or you also call it, Loternese screw. If you are able to put a good Loternese screw that is, passing from the bring like the fourth, the fifth hole all the way to the ECM. If you can get that screw, that's a good screw. That will significantly increase your stiffness on the periacetabular area. But if you are not able to do that, there are a few things that you need to consider. One of the things is your plate strong enough to withhold, the femoral head pushing it up. If it is strong enough, like this plate, we have some, yes, that's the screw that I was talking about. So if you have a strong enough plate, a couple of screws on the body of the pubis might suffice. But depending on your fracture pattern, if you have a fragment there, and if you put a short screw on the root of the ramus, and if your plate is not well contoured to the surface of the bone on that area, you could actually pull that fragment up, and it might be a displacing factor actually. So you have to think things into consideration before you indulge into putting that screw. But definitely, if you are able to get that long screw with good imaging, that significantly increases your fixation. And there are scenarios when that will be a necessity. In cases when you have a segmental fragment on your iliopubic eminence area, then that screw becomes a necessity. But in the fracture where you have one big segment of the anterior column, this fixation might suffice. And another thing that Mike raised was, the start point for posterior column screw. There are, classical start points that you see on the books. But the main thing is, are you able to get, a perpendicular screw passing through the posterior column fracture? And that perpendicular screw going through the posterior column fracture line is a critical thing that you have to take into consideration before indulging into where your start point needs to be. So pro-planning using, if you have a 3D MPR reconstruction ability with your whatever, pack system that you use, one of the things that we use in Ethiopia is, Radiant DICOM viewer. It's a free version of Radiant viewer, DICOM image viewer, where you can actually, reconstruct it and create your, trajectory from your 3D MPR reconstruction, and you can actually, precisely plan your start point as opposed to the traditional 3 centimeter, 2 centimeter anterior, lateral, medial, that sort of one hammer for everything will not work in every case. So it's actually good to do a proper planning with appropriate 3D MPR reconstruction using your image viewer will help you much better.
Yeah.
Thanks, Andy. Maybe you could send the details about that out to the group. We're running a little low on time, so I just wanted to give Dr. Solomon the chance to finish his presentation, and then we'll have final comments from the faculty. Sorry to interrupt the very lively conversation.
Okay, thank you all faculty for your comments. So this was a post-op X-ray at 2 weeks. Still, the articular surface is well maintained. The disimpacted part is still in its place in reduced position, as you can see from all the X-rays. So this was 3 months post-op X-ray as well. Still, the articular surface is well maintained. That disimpacted part is still there in its good position. So this also 6 months post-op X-ray. Patient has no complaint. He resumed his daily activity, and now he's farming. This all about the first case. So as a summary, our decision making was to open reduction internal fixation. The approach we used was lateral window with AIP approach. Then we reposition, we lateralize the femur head initially. Then our operative technique was elevate the impaction. Then we put a sort of iliac bone graft. Then we use an independent subchondral screws. Then we put the suprapectineal buttress plate for the anterior column, and finally we put a posterior column screw. Thank you so much.
Thank you, Solomon. Superb presentation. Like, so many amazing teaching points from you, and really amazing job showing the pertinent imaging findings and the surgical approach you took, and excellent comments from the faculty. Haley, I'll hand it over to you to just sort of moderate the last comments from faculty, and then take us out.
Sounds good. Thanks, Kieran. Kara, you've had your hand up for a little while. Do you have a couple comments? Oops, I think you're muted.
No, it's a remarkable case done with a tremendous level of skill. Not typical, and so hard to do, particularly after a week or so. So I wanted to address the question that someone asked along the way: when would you give up? When would you not do anything or do something less, right? And I'll start by admitting that we don't get many late cases here in my practice setting in Boston. So we don't get cold acetabular fractures that have been out 2, 3, 4 weeks. Those are rare. However, I have another population of patients that you may also have in your communities. I have a lot of geriatric patients, right? So a lot of these folks come in with these protrusion fractures and very, very significant, impactions and things like that. And obviously, we don't try as hard because we have the option of doing arthroplasty in a lot of those older patients if they're healthy enough to undergo it. And sometimes what we do is we just restore a little bit of the anatomy of the pelvis with an anterior protrusion plate, or even by pulling on the neck and just pulling some screws, knowing that what we're trying to do is we are trying to achieve some degree of stability and pain relief so that an elderly patient can mobilize a bit sooner and then potentially come to an arthroplasty procedure a few months later if they're doing okay. It's a completely different goal than doing this for a young person who obviously needs to have a functional non-arthritic hip for many, many years. That's all I wanted to add. Yeah.
Excellent. Thank you. Dr. Melkias, was your hand up again for one final comment?
Oh, sorry. All right then. Yes, so the reason I started about I raised about the point of starting the posterior column screw is that, the more we go lateral or displaced from the hardest part of the skin, then hardest part of the ilium, which is the sciatic buttress. I mean, compression of the posterior column and probably fracture would be a little bit difficult, or as we further tighten it, as we further tighten the screw, probably it might sink it inside the iliac wing. So that was my point. I mean, if we need to have a greater purchase or reduction of our posterior column fracture, then the more we go a little bit medial and posterior towards the sciatic buttress, then the anchor or the screw head or the washer probably would not sink in while we are tightening it further. So that was my point. Otherwise, the other question regarding the Luterna screw, which was asked by Dr. Sami, was that was my question, which is really answered nicely. So thank you. It's a great discussion and a great case. All right.
Excellent. Thank you. Any last comments from any of the faculty? All right, sounds good. Well,
I would like to thank the two presenters. I think Black. Hello, can you hear me?
Yep, you're good. Go ahead.
Yeah, so great cases from Black Lion. I think I'm inspired to go and visit Black Lion Hospital because these are really interesting cases. And a few things that I would just like to comment on is that these fractures are usually difficult to treat in resource-limited settings. First of all, they usually present late, and when someone comes 2 months down the line, you'll actually be doing more harm than help the patient. And again, on the other side, most of them actually don't have access to arthroplasty because they eventually end up developing post-traumatic osteoarthritis. So sometimes, we're torn in between, trying to help the patient and actually not doing nothing. And sometimes not doing something is the safer option. And we all know that it's actually, it has a steep learning curve. So to get more trauma surgeons doing this kind of procedures usually takes a lot of investment. It also needs special kind of instruments and, access to fluoroscopy and radiolucent tables. All these kind of things are not available in our setting. But nevertheless, really good cases presented today. And I think, yeah, that's it.
Excellent. Thank you.
And I just wanted to thank Kieran and all the participants from all over the world. These sessions just keep getting better. Thank you so much.
Yeah, two really good cases. I know I took a lot of notes and a lot of pearls from both of them. So thank you to all of our presenters and faculty. I just want to highlight quickly, Tasia in the chat posted the post-conference survey. So if you're able to fill that out, that would be immensely helpful for us planning our future conferences. Kieran, any last words?
Yeah, I think Pierre-Marie wanted to say something. And also, Haley, do you mind just pulling up our outro slides? It's in the same PowerPoint that you had earlier. Those will... Go ahead, Pierre-Marie.
Thanks, Sharon. I just wanted to kind of echo Brian and Dr. Madison comments. You know, as trauma surgeons, the more you do complex stuff, the more you want to do them. And so I think that knowing your limitations, again, this was this message last week. I'm giving it again, echoing what he said. Those are really, really hard cases in expert hands. And so it's very important to understand what you have available, what your resources are, and if sometimes what one of my mentors was what called masterful neglect sometimes, if it's not, you know, wise not to do. So if you don't have the resources, just be wary about, you know, going into these, because the complications are sometimes more than we think if we try. And all trauma surgeons know this. We want to do complex stuff, and we get excited doing these cases, but the patient first, always. So just, that was my comment. Thank you.
Thanks, Pierre-Marie. Just thank you so much to everybody who was involved in preparing this session from the HGOC and SONA Global side of things. Thank you, Haley, for moderating. Thank you to all the faculty. So just as a reminder for all of our participants who are still on the line, if you fill out the pre and post session surveys, we'd be very happy to give you like a little certificate of participation on behalf of HGOC for your participation in this in this course. Now, of course, we will record all of these sessions. They will be available for free online. You will have access to all the pre-recorded lectures, articles, and these live sessions, and can go through it at your own time and give us feedback at any moment. And we would be very happy to receive that. Haley, next slide, please. Yep, that's it. Okay, so those are the links for the pre-conference survey, the post-conference survey, and our email address. So please feel free to reach out with any questions at all. And thank you so much to all of our participants today for joining. Really proud to run these and really happy to have you. Have a great rest of your day and a wonderful weekend. We'll stay on the line in case there are some remaining comments and questions, but we'll end the recording there. Thank you so much, everybody.
Thanks so much, everyone.
Okay.
Bye.